So, hello, good evening, everyone. Welcome to PSC examination preparations. Today, we'll be discussing MCQs from the subject of OMFS. So, the questions what I will be discussing will be from your previous papers. So, in and around where to study, what to study, how to study, all those things I will be discussing. So, dear aspirants, please make sure you read the following topics for your examinations. The first and foremost is local anesthesia. And this local anesthesia, you don't have to go into details of everything. Generally, the questions asked is which is the most toxic, which is the shortest acting local anesthesia, which is used in children. So it's a straightforward questions which are asked when it comes to local anesthesia. Composition, complications, a little bit about the blocks. Then you should pay a little more attention to impactions, extractions, and fractures. So these three topics are the ones, and TMJ, four topics. Okay, you need not go into much detail about orthognathic surgeries and all, but an overview will really help you to crack the seat. So there are a lot of books in the market which you can read. There is Dental Pulse, there is Gauri Shankar, there are Bhatia, there are n number of books available in the market. Dental Pulse book will give you a very good insight, as well as subject-wise MCQ books are also there, individual subject-wise. So those books also you can go through it. Okay. So the best method is, there are two methods of preparation. The first method is read subject by subject, go one by one. And the other one is take the original question paper like PSC dental surgeons question paper, last 10 years time papers if you have, take one question and go back to your textbooks. The particular chapter, go back and read. So once you read there, what will happen is the whole area you will be covering. Suppose a question is from general surgery tetanus, you read entire chapter of tetanus. So in that way, you will get the pure concept of that. So in fact, the question bank of the board, you will be learning. So in this way, you can do an anterior grade preparation where you're reading topic wise, subject wise. And second one is retrograde, where you take the question and go back to the chapter. Okay, so let's start today's session. So I will be giving you questions and I will be telling you the answers. More than the answers, you should be aware of how to go for that answer and how to read in and around those topics. That is more important. So the first question of the day is, long buccal nerve is a branch of. Now, this buccal nerve is a branch of what? Right. So you have got your trigeminal nerve. So in your trigeminal nerve, you have got ophthalmic, maxillary, and mandibular. So first of all, you should know entire branches of trigeminal nerve. Ophthalmic, it's okay, but maxillary nerve and mandibular nerve, in and out, there is no excuse if you don't know, because that will help you in anatomy also, as well as in your oral surgery also. So now coming to your, the first one, long buccal nerve is a branch of. Now, see, we have got, this is a branch of mandibular nerve. Okay, let me tell you straightforward. So now option 1 and option 3, both are branches of mandibular nerve. So you should know the mandibular nerve branches. So from the main trunk, you have got two branches, that is your medial pterygoid nerve to medial pterygoid and meningeal branches. Both starts with M. The main trunk, MM. And from the anterior trunk, you have got sensory branch, the buccal nerve. So this is the buccal nerve, what they're asking. So buccal nerve is a branch of, sensory branch of anterior trunk. And the other motor branches are muscles of mastication nerves like masseteric, deep temporal, nerve to lateral pterygoid. And from the posterior trunk, we have got auriculotemporal nerve, lingual, inferior alveolar. So the question was, buccal nerve is a branch of what? It is a branch of anterior trunk. So anterior division of mandibular nerve is the answer. So similarly, only you read this question, that's not done. You should learn maxillary nerve and its branches, mandibular nerve and its branches, facial nerve and its branches. So out of the 12 cranial nerves, this fifth and seventh cranial nerves you should learn in and out. There is no excuse for that. Next question. Injudicious use of elevation or elevator of mesial surface of which impacted mandibular may result in fracture of mandible. Okay, so this question is from the impactions. So we generally elevate from mesial to distal. So which impaction, if you elevate mesial to distal, will create fracture in the mandible? So let us go option by option. So this is a very simple question actually. Vertical impaction, you can elevate on the mesial aspect, it will come out, no problem. Mesioangular, you can elevate from the mesial aspect after doing the bone guttering, it will become vertical. Horizontal and distoangular. Now these two are the ones which you should be very, very careful about. Horizontal impaction, when you do the bone guttering, right? The problem with horizontal impaction is damage to the nerve will be more. Damage to the lingual nerve will be more. So you should be very, very careful about that. Whereas the distoangular, already the tooth is bent, and if you're pushing it more backward, it can create a huge impact on the ramus of the mandible and could result in fracture of the mandible. So the here answer is distoangular impactions. So one of the most common is vertical impaction. Mesioangular is the most easiest impaction to do. Distoangular is the most difficult impaction to do, and horizontal impaction causes nerve injuries. So these are the high yielding facts you should learn in and about this particular question. Coming to next question. Which of the following is the most difficult impaction of a third molar teeth? Again, same thing. It's a modified version of our previous discussion. Which of the following is most difficult impaction? Partially impacted tooth, you can take it out. Vertically impacted, it's very easy. Mesioangular, it's again the easiest and the most common. The most difficult is distoangular impacted tooth. Distoangular impacted tooth is the most difficult. Again, it was the repeat of the previous question, only the applied aspects are different. Now coming to next question. After reduction of acute dislocation of condyle, so condyle is there, maybe a hit came and the condyle got deviated. Which one of the following is important? Right. So once the condyle got deviated, it has to be fixed. So what will you do? Whether muscle relaxant, it is which one of the following is important? Muscle relaxant, immobilization, antibiotics, or antiemetics. So here antibiotics and antiemetics can be given later, and antiemetics it's not required also unless and until patient has a vomiting sensation. Now, once the condyle is dislocated, it has to be brought back to normal position. Then only the treatment starts, right? So this condyle management of dislocation, I'm just going to tell you in and around the topic. So this dislocation of the condyle or the mandible, there is non-surgical and surgical. This is basically condyle dislocation, non-surgical and surgical. What is this non-surgical management? Manual reduction of dislocated condyle. You have to manually make sure if the condyle which was broken comes back to normal position. So this you can start first, there will be pain. So you can start with sedatives, physiotherapy, and even in the glenoid fossa, you can give an injection shots. So by doing this, you can reduce manually. Patient's pain will be less. Next technique is chemical capsulorrhaphy. So here you can inject some sclerosing solution into the supporting ligaments of the joint, and which will produce fibrosis. And then the sclerosing agents are sodium mauryate and sodium tetradecyl sulfate. So this is again an MCQ question which you should know. So supporting ligaments will become fibrous, and you can slowly manipulate and bring the condyle in position. Third option you can use is arthroscopic sclerotherapy, occlusion, equilibration, and even exercise will bring it. That was all non-surgical. Surgical procedures are divided into three categories. Procedures to limit condylar translocation, because if a dislocation has happened, it has to be brought back. Next one is procedures to eliminate blocking factors in the condylar path. So first one is limit the condylar translation. Second one, you have to block the factors which are leading to dislocation. And third option is both, that is 1 and 2, which limit the condylar translation and eliminate blocking factors. So procedures to limit condylar translation, the first option what you can do is capsulorrhaphy. It is tightening the capsule to prevent excessive movement of the condyle. So the capsule, the fibrous capsule and all should be strengthened. Here the strength has to be there. Otherwise, the condyle will be moving forward and backward. Second is anchoring sling. Of some fascious letter transplants can be used and it can be secured to zygomatic arch. So because of which excessive movement of the condyle will be stopped. Coronoid process can be ligated with the zygomatic arch also. That is called Daughtry procedure. Lateral pterygoid myotomy and some blocking soft tissue and hard tissue procedures are there. So Daughtry procedure, which I told you, very important. The zygomatic arch is osteotomized and is depressed in front of the condylar head. You have condyle, the zygomatic arch is little broken and kept below the condylar head. So the condyle will not glide above that. Daughtry procedure. Okay, so these are some of the procedures that the combined procedures: lateral pterygoid myotomy, condylotomy, and condylectomy with high condylectomy. So these are the management of condylar dislocation, non-surgical and surgical. So here, first and foremost, see, these all are important. So you can give a muscle relaxant and then immobilization. Which one is more important? Immobilization is more important. You have to stabilize that area. Otherwise, if you keep on moving that area, there will be malunion over a period of time. So you have to stabilize first. Okay, to stabilize that area, bring back to its normal position, and then muscle relaxants can be given. Next question. The first direction of forceps movement in extraction of mandibular premolar. The first direction. Okay, so this first direction is extremely important. So you have got the normal extraction methods. You have got apical, buccal, lingual. In any extraction, the first movement has to be apical. Just a second. Yes, so the first direction is apical and then followed by buccal, lingual, and the method by which you will remove the tooth is by rotation movement. By rotation, you will take it out because this is the premolar tooth. Next question. This is very interesting question. Calcitonin spray or injection is used to treat which one of the following condition? Okay. So this calcitonin spray is basically a nasal spray. Is used for treating osteoporosis, bone-related problem. Okay, and certain bone-related conditions it does. So basically, this is used in women who are having 5 years past menopause. So for them, this is given. So by using this calcitonin spray, it slows down the bone loss, increases bone density, and reduces the risk of spinal fractures. Right.
You.
Yes, please mute yourself. Then in Paget's disease of bone also this is used. It's all bone related problems. So it helps regulate abnormal bone turnover and relieve the bone pain over there. Then hypercalcemia, you can use calcitonin spray in case of high blood calcium levels. You can use this, and bone pain from fractures also can be reduced. Metastasis also can be reduced by using calcitonin spray. So basically, how does this calcitonin work in this osteopetrosis? So basically, calcitonin has, this is a hormone produced by the thyroid gland. So it reduces the bone breakdown by inhibiting osteoclastic activity. That is an answer. It inhibits osteoclastic activity. It lowers the blood calcium level by reducing calcium release from the bones. So that is extremely important. Yes, questions is someone of you have asked about the questions. These questions will be live, it will be there in the YouTube. So always you will get this. Right. So these are the methods what you should be knowing. Calcitonin spray is used in the treatment of osteopetrosis. So this question, importance of calcitonin, I have explained few more things, where all it can be used, how it can be used, that you should know very well. Answer is osteopetrosis. Next question. A 3-year-old male child sustains trauma to chin. So in the chin, one trauma came. Towns view shows that radiolucent line at the medial cortex and deviation of the condylar head. This is a very important statement. Deviation of condylar head. The fracture is classified as simple compound green stick, no fracture. So here there is a deviation. So this is the classification. When there is no displacement, that is simple fracture. Deviation, compound fracture, broken into two parts and separated, compound. Completely displaced and it is coming out of the tissues, that is comminuted fracture. Right. And then you have got a green stick fracture. So green stick fracture is basically just a hairline fracture where the bone will only bend. Bone will only bend. But here you see that there is deviation of condylar head. This is deviation. So there is a fracture. So this comes under compound category. Okay, green stick is a fracture where only bending of the bone. There is no deviation. There is a bending of the bone. So it can come under compound category. Next question. Best treatment for fracture of pencil thin edentulous mandible. Pencil thin edentulous mandible means very thin ridge, very small thin ridge. Little force you apply, the mandible will break. Of a 70-year-old patient with hypertension. So it's 70-year-old and hypertension is also there. So here, what you can do? Dental wire, gunning splint, denture wiring, reconstruction plate, mini plate. Yes, I want you to answer. Please answer if you can. See, for mini plate, reconstruction plates, and denture wiring to be given, you need adequate strength towards the bone. So here, there is a paper thin edentulous mandible. So what best can be between two options now? So two we have to eliminate. Dental wiring and mini plates eliminate. So you have got gunning splint and reconstruction plates. So the reconstruction plate is given when there is deficient bone or there is no bone at all. So those areas we give reconstruction plate. So that is the ideal answer. But it is an edentulous area. So gunning split can also be an answer. So this is basically a controversial question. If you say A, I will say 3. If I say 3, I will say 1. Right. So because it is edentulous and 70 years old, you don't have to be so much aggressive by giving reconstruction plate. You can go with the gunning splint as the answer. Next question. Linear symphysis mandibular fracture is best surgically treated by. Yes. Now, linear symphysis fracture. Okay. So you have got in this fracture load sharing, load bearing, compression, and non-rigid fixation. Now, where is this fracture? It is in the symphysis area. Symphysis area is here. Symphysis, parasymphysis, midline area. So this is best treated by load sharing, load bearing, compression, or non-rigid fixation. Generally, compression, this you have to use that like eccentric decompression plates. Whenever you do a plating on the lower border of the mandible, the upper part will just open up. Okay, because of the stresses involved. So here you use eccentric decompression plates. So that is basically at the angle of the mandible. Here we are talking about the mandibular fracture at the symphysis region. So this can follow the Chamfy's osteosynthesis line. Chamfy's osteosynthesis line. And on the Chamfy's osteosynthesis line, you can give your mini plates. The mini plates will take up and the compression will be given over there. So answer more appropriate could be compression by giving mini plates by following Samfish osteosynthesis line. So what is Samfish osteosynthesis line? Please go back and read. Next question. Best approach. So now, previous question only, linear symphysis fracture. So now there are different options given here by mini plates. So mini plates, you can give your open reduction internal fixation. So the dual mini plates are generally given in linear fractures, simple fractures, stable fixation, or minimal hardware where you don't have to do much, require a little bit of surgical exposure. That is dual mini plates. Then reconstruction plate is generally given in comminuted fractures, unstable fractures, or atrophic mandible. Reconstruction plate. So our previous question was atrophic, very thin mandible. So reconstruction plate also was a probable answer. That's what I told. It's a controversy. And the large screw fixation can be given in oblique fractures, excellent compression technically when it is required. So that is your large screw fixation. So that are the things which you should read in and around that. Next question, best approach to the subcondylar fracture is submandibular, preauricular, retromandibular, Alcaid-Bramley. Alcaid-Bramley is the excellent and the latest one which has been added to the category. The facial nerve enters from your, it comes out from stylomasted foramen, it travels over the ear, and then it enters the parotid gland from the posterior medial surface. So once it enters the posterior medial surface into the parotid gland, it divides into 2 branches, and the 2 branches again subdivided into 5 branches. So this Alcaid-Bramley incision is a modified preauricular incision. Preauricular incision, modified version is Alcaid-Bramley, which takes care the facial nerve is not damaged. So at the subcondylar region here, the facial nerve can get damaged. So in order not to injure the facial nerve, even open reduction, internal fixation of condylar fractures are not done, not to damage the facial nerve. So Alcaid-Bramley incision is the best approach. So read back about Alcaid-Bramley incision. Next question. Which one of the following is not correct in respect to mini plate fixation of mandibular fracture? Not correct. So that means the wrong one, we have to take it out. It is in the mandibular fracture. So mandible. So eliminates extraoral scarring. See, mini plate and extraoral scarring will be because of an injury. So this has nothing to do with this actually. Second, so eliminates extraoral scarring, not correct in respect to mini plate fixation. Okay. Next, prevents facial nerve injury. If you do a mini plate, facial nerve injury can be corrected. It's not correct. Maxillomandibular fixation is case dependent. Yes, that is patient to patient, and it is from case to case dependent. And one plate in interforaminal region, that is also correct. So which one of the following is not correct in respect to mini plate fixation? It prevents facial nerve injury. See, one thing is when you're doing the fixation plates in the mandible, you have to follow the Chamfry's osteosynthesis line. So this is not the answer. Eliminates extraoral scarring, that is not correct. That will always be there if an injury has happened. We are treating the fracture, not the scars, pertaining to fracture management. Next question. Lax screw fixation of mandibular fracture is commonly done in. Right. So this is the same. This is Chamfry's osteosynthesis line, what you are seeing here. And the explanation I have just given you. The lax screw fixation is generally done in simple oblique fractures. Right. Excellent compression and technically demanding cases, you do this. So basically, your anterior mandible fractures here, all lax screws you can give here. So option A is the answer. Next question. Dearrangement of occlusion can occur in which of the following events following trauma? Dearrangement of occlusion. Fracture of the maxilla, yes. Occlusion can go out. Mandible fractures, yes. Dental fracture, yes. TMJ, effusion, dislocation, yes. Dental injuries, displacement of the fractured teeth, yes. So in all the above conditions, dearrangement of occlusions will be there. So all of the above is the answer. Next question. Tension band at the alveolar segment. So at the alveolar segment, if you give a tension band, but may not be required with. Yes, this is what I was talking previous slide. See now at the angle fractures, if you give a plate here, so that will put the compression, and but because of the tension, it will open up. So the best answer, tension band is not required for eccentric dynamic compression plates. E, small letter E, and DCP we write like that. Eccentric decompression plates. So that is a plate where the compressive force as well as the tensive force, both the forces are applied. So it is countered. The comprehensive or the compression force is applied at the lower border of the mandible and also at the alveolar socket level. So the opening of the segment does not take place. Answer is B, eccentric decompression, dynamic compression plates. Next question, crossbar elevator works on the mechanical principles of wedge, lever, gear axle. This is a very common question, right? So the crossbar, the maximum force is generated on that, and the mechanical advantage is 4.6. So 4.6 times the weight of the operator, the force is applied on the two. Whereas apex elevators, wedge and extraction forceps uses only 2.5. And the straight elevator has a mechanical advantage of 3. So this all things we should know which one, which instrument, which principle, and what is the mechanical advantage of each. So read a little bit about that also. Next question, most common gauge of needle used for aspiration biopsy. So generally for aspiration biopsy, gauges are like between 22 to 25 we use. This is for fine needle aspiration cytology, between 22 to 25. So to be more specific, the 22 gauge needle is used for what you say. This is used for depending upon the lesion site and tissue density. So this is used for thyroid, lymph nodes, breast lumps, and salivary glands. I'm talking about 22 to 25. So advantages, there is minimal trauma, less bleeding, and better cell will yield. Whereas 14 to 18 gauge is used for core needle aspiration or true cut biopsy for larger lesions when cytology is insufficient. So answer is 22 to 25. So 22 is there. That is for aspiration cytology. And for core needle biopsy, 14 to 18. And for bone marrow aspiration, 16 to 18 gauge needle. For bone marrow aspiration, 16 to 18 gauge needle is used. So please be very specific about this particular question and its explanation. Answer is 22 gauge for this particular question. Next question. Reducing agent used in local anesthetic solution. So this is the basics which you learn in third year BDS. So this is the composition of local anesthesia. So the reducing agent is sodium bisulfite. Antifungal agent is thymol. Vehicle is ringer lactate solution. Preservative is methyl paraben. And vasoconstrictor is adrenaline, which is in 1:50,000, 1:80,000, 1:1 lakh, and 1:2 lakh concentration. So this one you should know that. This is the composition of LA. Here answer is sodium metabisulfite. Next question. The most common complication of PSA nerve block is hematoma formation. This is one of the direct questions which you should know. The most commonest complication is PSA nerve block is hematoma formation. In inferior alveolar nerve block is facial nerve palsy. Because most posteriorly, when you go behind the angle of the mandible, the parotid gland will be there. And parotid gland is supplied by 5 branches of facial nerve. So there, facial nerve gets affected. Next question. The local anesthetic with highest tissue irritating property. So this is basically a factual one. So it is basically propoxycane. Okay, propoxycane is the one. The answer is procaine over here. Now some other high yielding facts are the most common ester group which is metabolized by plasma cholinesterase and some in liver. So this is ester group. Ester groups are the ones which are metabolized by plasma cholinesterase enzyme and in liver also. Whereas amide groups are metabolized only in liver. This thing you should know. And it is contraindicated in patients with malignant hyperthermia. Amide groups you will not be given. Prilocaine metabolized in lung also. Procaine, it is the first synthetic LA metabolized in kidney. Chloroprocaine, it is the least toxic, the safest. It is given for children also. Short acting. Tetracaine, toxic, compatible with sulfonamides. Cocaine has vasoconstrictor property. Then propoxycane, it is always mixed with 2% procaine, useful in absolute contraindicated of amide type of patients, effective in inflamed tissues. Lidocaine, first non-ester type of LA, mepivacaine. So this is a table which you should go through it. Right, so these are all the MCQs which has been tabulated and made into a table. These are all MCQs. Next question. Diplopia is most common with. So diplopia is a double vision generally associated. So diplopia is generally associated with nasal fracture, craniofacial, zygomatic complex fracture, or mandibular fracture. The answer is C, zygomatic complex fracture. So the commonest clinical feature what is seen with ZMC fracture is diplopia. And please understand, unilateral diplopia is more dangerous than bilateral diplopia. Unilateral is more dangerous. Horizontal fracture of maxilla is also called as. So this is a straightforward question, right? So this is nothing but Leefort 1 fracture or floating fracture. The answer is C, both of the above. Just that you know the option A, don't jump and write option A. Answer A will be wrong. Both 1 and 2 are correct. So answer C is the answer. Next question. The radiographic view of choice for demonstrating nasal fracture is. So whenever there is a fracture, you should take two radiographs perpendicular to each other. So there is a nasal fracture, one you will take an OPT, right, straight, and another you will take a lateral view. So the answer will be true lateral or lateral nasal view, if anything is there, something like that. So true lateral is the best choice for demonstrating nasal fracture because X-ray should be taken perpendicular. The two X-rays should be taken perpendicular to each other. True lateral view is the answer here. Next question. Most common dislocation of the condyle is in which direction? So whenever there is a hit, the condyle, it goes anterior, inferior, and medially because of the muscle pull. Antero, inferior, and medially. So please remember that. So for this, you should know all the muscle pulls of the fractures, right? Different fractures, all muscle pulls in which direction the anterior fragment and the posterior fragment moves. So that is a one big class in itself. That also you should know this. Next question. Which instrument is used to cut the tooth in lingual split technique? So it is basically chisel, which you know that. Right. Straight elevator is used for elevating the tooth. Surgical burr is used for guttering, to remove the excess bone. Right. To cut the tooth is the lingual split technique is chisel. Next question. Mostly cleft lip surgery is done at what age? Right. So basically, the cleft lip initial surgery is done by Millard's rule. What is the Millard's rule? 10 weeks of age, 10 grams of hemoglobin, right? And 10 ounce the baby should be. So the 10 weeks is the answer over here. And the cleft palate surgery is 1.5 years. That is 1.5 years is for the cleft palate surgery. Next question. To give field block, LA should be deposited near field block, right? Infiltration is peripheral nerves. This is field block. So large branches of the main trunk or the peripheral nerve. The larger branches we should give. So option B is the answer. These are all straightforward questions, so you should be able to handle this. Next question. Signs and symptoms that commonly suggest cardiac failure in a patient being assessed for oral surgery. cardiac failure, when the heart is not working, so the blood circulation stops. And when the blood circulation is not proper, the blood goes to lungs for purification. That is also not proper. So what happened is eventually it results in dyspnea, difficulty in breathing. It happens, right? So difficult dyspnea happens and ankle edema also develops. Out of all the things, these are the most appropriate answer. Right. So do a little bit of background study for this. You will get the answer correctly. Ankle edema and dyspnea are the ones which are signs and symptoms that yes, cardiac failure can suggest a cardiac failure in a patient. If there is dyspnea, patient has, or you're taking a patient for surgery, patient has dyspnea, patient has ankle edema, he can have a cardiac arrest in the operating table. So that is why you should have a proper case history. Next question, in systemic LA toxicity, there is post-depression convulsions, post-convulsion depression, convulsion depression. Always remember, always, that is life mantra. There is excitation followed by depression. Anything. You drink tea, there is excitation. After you drink more, there is a depression. You drink alcohol, initially excitation followed by depression. You eat biryani, initially you like it. After some time, when your tummy is full, you start hating it. So there is post-convulsion depression. So convulsion, there is an excitation followed by the patient will go into a state of depression after the epileptic attack. So option B is the correct answer. Excitation followed by depression. Next question, Campbell's line is seen in X-ray falling projection. So Campbell's line generally, when your condyle has fractured and it is in the glenoid fossa, that time you try to take an X-ray and you get this Campbell's line. So the best view is transpharyngeal view, where you can see Campbell's line very clearly. So this is basically a radiology question also. So all the views, transcranial, right, transorbital, Waters view, which degree, 30 degree, 15 degree. There is a table in Dental Pulse book also where you can read in detail about all the different views, indications, contraindications, and angulations. Please read that. Next question, the most common site for mandibular fracture. So it's basically the condylar fracture, and in the condyle, it's not the head, the neck of the condyle gets fractured because the neck is the weakest part. So once the neck gets cut, condyle deviates. So it's a condylar neck, that is B is the answer. Gunning splints are used when the patient is edentulous. This you know that gunning splint. It's like an acrylic plate is made and then a hole is kept in the center where patient can eat food and the medicines. Next question. Maxillary tori are removed by. Yes, so maxillary tori, if it's a big tori, you cannot remove with your osteotome completely. And chisel and mallet is outdated. So you can cut with small segments, you can cut with your burr, and then with osteotome, you can remove the small pieces. Right? Or with a round burr, you can remove that excess bone also. So, and best answer will be second one, bone burr and osteotome for maxillary tori. Right. So, dear aspirants, these were some of the questions which are asked in oral surgery. These are hand-picked questions. The major intention from every chapter it was picked is to have a glance at how variety questions are asked. So please read fractures well, TMJ chapter well, local anesthesia, extraction, impaction, a little bit of cyst also. So these are the ones which will help you to solve the major questions. Okay, so these are the basic questions. The objective of my presentation is to show you that there are topics rotate. There will be doubts, there will be a lot of things. So in the WhatsApp group, you can post your questions to the coordinator. The question will come to me and I will attend to it. Okay. So these questions and many more PSC questions are there. These questions are there in our Aden2 app. Okay, just get into the Aden2 app and our coordinator is there, our number is there. You can speak to the coordinator. There a flood of questions, everything related to this in and around. The whole question bank is there. Okay, so that's all for the day, right? So thank you so much. This is just the tip of the iceberg. The major things only I have discussed. In 1 hour, 2 hours, whole surgery cannot be done. You also know. So please learn, read in and around, and don't study like a PSC exam. Study like a NEET exam. Give 100%. Right? It should not be PSC. Generally, those people give who are already working in some clinics, or those who are having one source of income and then they are giving a try. So PSC, when you're appearing, it should not be your second preference because you are working somewhere. So first is working. You study in such a way, this is the only go. So no mistakes. Some other books I will tell you. Dental Pulse is one book. Gauri Shankar is second book. Dentogist is third book. And then you have got a book by Sandeep Goyal. It's a synopsis book. Individual books like Prabhakar, very good. All subjects books are there. Prabhakar. Then Ritu Duggal is one more book. There are n number of books, right? Market is flooded. So best thing is you get in Dental Pulse and Gauri Shankar and solve this PSC original questions retrograde. Take the question, go to chapter. So with this, you can easily solve all the questions. And you would have noticed that generally PSC questions are not like NEET questions. NEET question this year it was like 4 or 5 line question. It is taking a lot of time to read. And then the answers again, A, B, C, D options, it is time consuming. Generally PSC are straightforward questions. So if you know, know. If you don't know, you don't know. There's no guesswork like that. Comparatively, it is easy. So all the very best. Do your best. Thank you. Thank you so much. Thank you.